For me. And welcome everybody over here to the Senate side, our House colleagues, and want to go ahead and do you want to go ahead and start with any opening comments or your presentation? Please, ma'am.
So good afternoon. I don't know, are these working? Yeah, I'm on green. Okay. So good afternoon. Just introducing the conferees from the House side, Chairman Sam Creekmore, who is the Chairman of Public Health, and Chairman Joey Hood, who is the Chairman of JED-A and our former Medicaid Chairman last term. So thank y'all for meeting us today. Mr. Chairman, I guess we had sort of discussed preliminarily that we would both just kind of present our positions, right? So, okay, so I'll be happy to start. So House Bill 1725, which we entitled the Healthy Mississippi Works Act, would direct the Division of Medicaid to enter into negotiations with CMS for a 1115 waiver. And so the conditions are to provide healthcare coverage for those ages 19 to 64 from up to 138% of the federal poverty level as defined in the Affordable Care Act. The conditions for that in our bill were they must be employed for at least 20 hours a week, enrolled as a full-time student, or in a full-time workforce training program. If they voluntarily disenrolled from their insurance coverage, they would have to sit out for 12 months. The delivery of these services would be through the managed care or MCOs. The MCOs would be charged with providing workforce training, skills building, education to enhance careers or finding jobs, and also to provide financial literacy materials as well. The enrollees would have access to all the same medical benefits available to adults as described in the ACA, which are hospital, physician, ambulance, and non-emergency medical transport. The funding of the program would be a combination of federal and state funds at a 90-10 match. The state share of the match would come from an assessment on the Medicaid MCOs. And there is a provision that if the federal match ever dropped below 90%, that the waiver would end and the plan members would be disenrolled. However, we had in the bill as well that if the waiver and its work requirement were not approved by CMS by September of this year, then the Division of Medicaid would still have to cover this eligible population with the same provisions as described in the waiver, but just through a state plan amendment. We put a 4-year repealer in our bill, whether it's through a waiver or through a state plan amendment. There was a 4-year repealer in our bill, just as a safeguard or, just to, if anything didn't go how we anticipated, that it would repeal in 4 years. We estimated on our plan that there could be as many as 200,000 people that would be benefit through our program with regard to gaining health insurance. We believe that the cost to the state is estimated to be about $150 million a year. And we also believe that the assessment on the MCOs is about $150 million a year as well. This doesn't include any of the cost offsets as are listed in plenty of studies. Very important, though, to emphasize that the federal government provides an incentive to non-expansion states in the form of a 5% FMAP to our traditional Medicaid program for 2 years. And that is a significant amount of money, which would bring in, we believe, about $650 million over a 2-year period. We believe that amount of money could run this program for 4 years on its own. So basically, we viewed it almost like as a pilot program that the federal government would pay for, and with the safeguards of having a 4-year repealer. And so that's really kind of just a summary of the House position as we passed it, I guess, early March. So.
All right. Thank you. I'll go through our proposal. So we're looking at, we did not name our bill, but we too will be applying for 1115 waiver. to cover persons between the ages of 19 and 64 and who make less than 100% of the FPL. With either they're employed for at least 120 hours or more in a month in a position where health insurance is not paid for by the employer, enrolled as a full-time student, enrolled full-time in a workforce training program, enrolled in at least 6 credit hours as a student working at least 60 hours a month in a position where health insurance isn't paid for by the employer, a parent or guardian that is the primary caregiver of a child under 6, a person who is physically, mentally, or intellectually unable to meet requirements as documented by a medical professional, or a primary caregiver, disabled child, spouse, or parent, provided that the disabled person qualifies as a disabled individual under the Social Security Act. Anybody who has insurance and voluntarily disenrolls from private or employer-sponsored insurance would not be eligible for a period of 12 months, just like your program offered. The coverage group shall not include non-U.S. citizens. The division shall verify eligibility quarterly. The division should make forms and application processes as simple as possible. The funding source for our match is also going to be from the MCOs with a 3% tax. Any amounts generated from the assessment that's in excess of the amount needed to cover the state matching funds may be used to enhance provider reimbursements for those services most utilized by the coverage group. If CMS rejects the work requirement and or the funding source assessment, all parts of the plan will be repealed on the date that any of these happen. CMS rejects the work requirement and the funding source assessment. CMS withdraws or terminates any waiver that CMS previously issued as required by this act. If a court nullifies the work requirement and or the funding source assessment, and our cost estimates, we originally were looking at about 80,000, but after further review and taking a look at some of the Kaiser Foundation numbers, we've moved that down to about 74,000. We estimated the per member per month capitation rate to be about $651, generating over $578 million. The state share of that would be about $132 million. The MCO tax on that 3% would be $142 million. And so the difference between the state share and the revenue would be a plus about $9 million to the plan. And so that's an explanation of our bill.
So, Mr. Chairman, let me ask you, on your cost, you said 70,000, but did you mean 70 million? The cost to the state share?
State share is 132 million.
Okay, I'm sorry, I misunderstood then.
I said 74,000 as far as possible enrollees.
Oh, enrollees. Okay, I beg your pardon. Okay, got it.
And I should have probably introduced my colleagues. Yes, to my right is Senator Nicole Boyd. She's chairman of universities and colleges, and at the end is Senator Bryce Wiggins, chairman of Judd A.
And former chairman of Medicaid.
And former chairman of Medicaid. You want it back?
You got credit. I need to get credit.
You
Chairman Hood got credit.
can come down here if you want.
No, you're doing fine, Mr. Chairman.
All right, would you like to have?
So yes, so I think, Mr. Chairman, I think right now there's some big differences between our two proposals. We obviously all know that. I believe the biggest obstacle for us to address is the federal poverty level as to where how far we can take that. The House is committed to drawing down the maximum federal dollars available. We don't believe that, to have the federal government being willing to pay 90% and the state pay 10% or 10%, we believe that, we hear a lot in this capital about we're going to run it like a business, we're going to run the state like a business. And I don't know many businesses that wouldn't take a deal of I'm going to give you 90%. All you have to give me is 10 back. And so, that position getting up to 138% of the federal poverty level is critical to us. We believe that is the most responsible way to run this program, and in terms of taxpayer dollars, that we would maximize that and enroll the most people doing the most good. So now we realize on our plan, or on our bill, we had all of that 130 all the way up to 138% on just managed through the MCOs. We have heard the concerns about the exchange, about not wanting to, ruin the exchange or destroy the exchange. And so as a compromise position, we are willing to take 100, leave 0 to 99 on the MCOs, just as our bill provides, but have 100 to 138% of the federal poverty level. Those individuals stay on the exchange, and with the state paying deductibles and copays so as to get the approval from CMS under ACA to get the 90% match, draw down the 90% match, and also receive the 5% incentive on our traditional FMAP, which is, $650 million, $700 million, which I believe anybody would agree that's real money. So that is what we would like to offer to you guys, to take back to your membership, your leadership, and to see where you would be. We realize there's more than one way to get to 138%. And so I think that for today is the biggest obstacle that between the two plans.
I've got a couple of questions, and I'm going to turn it over to Senator Boyd for a minute. You're also going to be paying the premiums on those, the premiums, the deductibles, and copays on that population from 100 to 138. Is that correct?
Well, this federal government would pay the premiums until they stop paying the premiums. So currently, the federal government pays those premiums. We do believe that in 25, maybe 26, I don't know exactly the date that they are said that those premiums I think those roll off. So yes, so the state would have to pay those, but we would leave those individuals on the exchange as, many of which who are on already. So, and then others from 100 to 138 that may not be on the exchange could be on the exchange. We would pay, the state would pay those cost sharing features.
Do you have an estimate of how many are currently on the exchange and how many that are currently not, but who would qualify for the program?
The only estimate that I have, well, I've heard a few figures, but taking the Commissioner of Insurance handed me a sheet in the hall, I don't know, it's probably been a month ago now, that he estimated based on the graph that he gave me, it had about 141,000 currently on the exchange, that as he listed between 100 and 138%, 141,000, I believe, was on the paper that he gave me.
And the costs?
Well, so the cost that we are using are the most recent studies are by the Hilltop Institute that actually took Mississippi, the current situation in Mississippi. As far as I know, the Hilltop Institute study is the only one that has taken our actual bill and the Senate's actual bill and determined the features of both of them, the cost, all those factors, and also provided what they refer to as a hybrid model, which is, I believe, what we are looking at. So, the hybrid, the enrollment estimate on a hybrid plan, they have it 197,000 people. The gross cost to the state before any offsets is 174 million. They include administrative costs and others, which are, about $12 million. And then they show, they do the cost offsets. They provide the cost offsets. So to answer your question, the hybrid, what they refer to as the hybrid plan in years 1 and 2 is 356 million in savings to the state. And then after years 1 and 2, it is a $31 million in savings to the state after the offsets that they provide.
What about 40 states have expanded, I think? Have any of them, I guess, how many exceeded the number of population that they estimated at the onset? I think 40.
Well, perhaps so.
Sort of to the point, and then the cost, have any of them maintained their cost within their initial projections?
I'm sure the answer is probably no. I spoke to an official in Arkansas back about a month ago, and he told me that they were running about, I think he said about 20% over what they projected originally.
That'd be a fair number for us to take a look at, about 20% over.
I can't answer that. I can't answer that. I am not an economist nor a healthcare economist. So I'm putting my faith in studies that I believe have been over and over shown that, every credible group that has done a study, whether it's the Hospital Association, the state economists, Hilltop, Manette or Manette, however you say it, have all come within their projections have been very similar and consistent. And so I have to put my faith and confidence in that. I will say that, 40 states have gone before us. I mean, no doubt. Actually, I find some comfort in the fact that 40 states have already expanded, and no one seems to be repealing their program. And, in the case of Arkansas, I know that they have had a higher cost. The way they've chosen to do their expansion is a more costly way, but they also have a very conservative governor who just renewed it. So, I believe that, there's good and bad in everything, right? But if the goal is to provide health insurance for our working Mississippians and help individuals lead a healthier life, be able to work, and hopefully get out of poverty, I believe that there's far more good in the proposal than there are, negatives. But again, in our plan, we have a 4-year repealer. So if it all runs sideways and our health outcomes aren't improved, if it is way more expensive than we ever anticipated, we don't believe the state can afford it, if it's just a disaster, that's why we put a 4-year repealer in ours. We can, walk away and do absolutely nothing. In 4 years, to renew a repealer, both bodies have to pass it again, right? Otherwise, we can just walk away and it could end. And we did that to give everybody some confidence in that we would have to come back and renew it should there be, just a complete disaster.
I certainly agree with you on the part about the working poor, but unfortunately, your bill, even though it has those work requirements in it, is still going to expand. So what's going to require those people to continue to work or do workforce training or go to school to improve themselves?
Well, we believe that 75 or 80% of these individuals are working, and Medicaid determines eligibility based on income all the time. So if you have somebody, especially when you get up to 100 to 138% of the federal poverty level, those individuals are making anywhere from $15,000 to $20,000, $21,000 a year. That income's coming from somewhere, and so Medicaid determines eligibility all the time based on income. And if individuals have an income, I think it is safe to say that it's coming from because they're working. But we also maintain the position that while 75 or 80% of the individual, we believe we do believe they're working. We're not willing to hold back the 80% who are working. We're not willing to not have a program just because maybe 20%, I mean, I'm just throwing that number out, perhaps aren't working or can't work. Maybe there's somebody in some small rural town where there's, 20 or 30 jobs. They don't have a car. They can't get to a job. There are a lot of reasons why that low percentage of the population may not be able to work at that moment anyway. And so, but we do believe that this is a program for working Mississippians. I mean, we in our bill, we have a work requirement in the first section, but we are not willing to hold back 80% of the hardworking Mississippians because we fear that maybe a small percentage somehow may game the system or something like that. We also charge the MCOs with tracking and keeping up with those individuals through workforce training and other things such as that. I mean, we're willing to, load the bill up as much as we can should a work requirement be denied, with plenty of things that show that the intent of the legislature is for this program to be a working program. But we don't want to hold back the 80% of the population who we know are working, simply because we fear that there may be some that get through that aren't.
Senator Boyd.
Thanks so much, Mr. Chairman. And I want to thank the House. The Senate obviously thought it was very important when we presented our plan to really look at this exchange option. So I appreciate the House kind of coming back with something and looking at that. And there's been some really misinformation about the exchange plan. So I appreciate y'all digging in and looking at this. One of the things that really concerned us was pulling all of those people off of the exchange plan, because we know in all parts of the state now, and looking at this, there are plans available to Mississippians who make 0 to 100, that make 100 to 138% that are really zero deductibles with what is being provided by the federal government and that. And so that we know that these plans really cover up to sometimes 48% better reimbursement for providers than what we are typically seeing with Medicaid plans. And that's a huge amount of number, because that equates to them having better access to health care. Because we have an issue with the state with the number of providers that are taking Medicaid right now. And so giving these people these better plans when they make 100 to 138 is something that is very important for us. The federal government, with the amount of money that they are providing for these exchange programs, are really contributing basically about 1.1 billion with estimates for those exchange programs. And I think that's something that's very important that really seems to be out of the discussion that people are not talking about right now. So I think these exchange plans are doing. One of the things too that Commissioner Cheney pointed out to us in a number of meetings is if we started pulling people off this exchange into just a traditional Medicaid, that we could look at some ramifications of what that does to the entire exchange market. And we know that that market goes up to 400%. So I think looking at this exchange and seeing the viable options with this exchange is really, really important. I want to go back to the numbers just a little bit of what y'all are saying on the exchange, because we've been looking at, we have talked to, there's really 2 states only that have kind of looked at hybrid models on this. One of them was very early on when the exchange market was not really fully developed. So that one kind of switched with that because that exchange market was not really fully developed at that time. But we've been talking to Arkansas, and there's vast different numbers that have been going around from the different reports. And I know y'all are like we are, that you have gotten vastly different numbers. So if you could just, what are y'all seeing? What did y'all see as the cost, looking at the average premium payment and then the average advanced cost savings sharing reduction payment on the Arkansas plan? What numbers were you getting at that?
So I'm not sure I understand your question because we are not promoting an Arkansas plan. So this is a Mississippi plan. This is not Arkansas. But to back up a second, you're saying the problem with taking the individuals off the exchange, we are offering as a compromise to leave them on the exchange.
No. I absolutely say we appreciate y'all coming back to us. with
Yes.
feedback.
So the concerns about taking, killing the exchange or taking the people off the exchange and all those things, we are, that's what we're offering to get to 138%, that we are, we are wanting to leave them on the exchange. Interestingly enough, though, with regard to, payments and reimbursements, I had a hospital tell me last week, the week before, and then I think another, hospital administrator was quoted recently as saying, but one told me this, that their number one payor, even beyond private insurance now, is Medicaid because of the enhanced MHAP. So, I mean, it's an ironic position that we're in, to say that, but he told me, that a CEO of a hospital in Mississippi said their number one payor is Medicaid because they're getting the average commercial rate now. And so, and also Medicaid pays every 2 weeks. And so they have been very happy and really, quite honestly, would prefer to keep everybody through the MCOs. We know that we are seeking a compromise position. And so, so we hand that to you, but no, I don't know all the ins and outs of the Arkansas plan. We have only looked at our plan based on the information in these studies that have been done specifically for Mississippi.
All right, let me go back to this. I want to address something that you just said too. You know, it's interesting. You talk from hospital to hospital and they will give you however many there are right now, they will give you a completely different opinion, and also who you talk to in that hospital. So I've had some that have reached out to tell me and some that I've called to say, okay, can you look at the plans and tell me, which is a better plan for you, which is the ones you prefer? And half as many say that they very much, over half of them have told me they really do like the exchange plans. Yeah. So, so I think that's where we're looking at on that. But tell me on the numbers that you're looking at, because we're looking at two sets of numbers. We're looking at those that are below the 99, which I think probably we've got similar numbers on. And then tell me the numbers, and it may be something we need to get back together on, is tell me the numbers that you're looking at if the state takes over and has to start providing the premium payments, which we would have to do if we went to this 100 and 138. We would have to take over those premium payments, and then we would have to take over the cost sharing reduction as well. So do y'all have numbers yet on that?
Numbers that they're same numbers that I just gave to Senator Blackwell. So yes, so the study that I would have to keep referring back to because it has been specifically commissioned for the state of Mississippi based on, I don't know that anyone else is doing economic impact modeling for Mississippi. And so the Hilltop Institute did this study way back in 2020 before anybody in this building was talking about any kind of Medicaid expansion. It was not commissioned by the House at all because at that time there was really not a whole lot of interest in even exploring this. But they have recently come back in April, so obviously this month, and provided us with these studies on this hybrid plan. And so those are the numbers that we are that we trust, and they are consistent with other studies that may be a little dated. So those are the numbers. And Senator Boyd, I agree completely. What I would offer today, you said maybe we need to take a look at it and come back. So I would love to ask you, I think that obviously there are areas where we are, we do not agree. But the biggest to me, I think the first hurdle that we need to come to between the two plans is getting to 138% of the federal poverty level. And we have compromised and said, we will keep that on the exchange to alleviate all these concerns about the exchange. So I would submit to you guys that take this proposal back that we are offering, or this compromise that we are offering, take this back to your leadership, take this back to your members, and then why don't we meet again tomorrow afternoon at 3 o'clock? We've got this packed house and people out in the hall. I mean, maybe I'll see if 113 is available so more folks can get in, and let's meet up again. And if there's something that you would like for me to take back to our leadership and our membership, then I am more than delighted to do. And then perhaps we can circle back up and kind of see where the two chambers are on that and continue to move forward in the process.
On the, we're going to be picking up the premiums. So the folks on the exchange right now, it's a sliding scale. Under your program, would there be a sliding scale so that the individual has some responsibility?
On the exchange? So the exchange would be run just like the exchange is currently run. So however, whatever the federal government provides for those individuals on the exchange, the federal government would continue to run. Now, we do have a bill proposed that has a state exchange, and we are certainly open to that in the House. Chairman Lamar is pushing a state exchange. We believe that there's some cost benefits to converting from the federal exchange to a state exchange. But obviously we don't have that before us right now, because that is also a proposal that is, going through the process. So we only can deal with what we know. So yeah, I see Senator Blackwell looking at, I didn't mean to say working it through the process. But so, so we have to deal with but yes, so whatever the federal government, however they structure their federal exchange, they would guide us through that. The state would have to pick up whatever the costs were, because that is the only way that we can get to a 90% match to draw down. Again, our commitment is to draw down the maximum federal dollar. And we believe that it's just good fiscal sense. It makes the most fiscal sense to draw down the maximum federal match and also receive the $650 or $700 million that incentive bonus, which we realize will likely go away. I don't believe that offer is good forever from the feds. So anyway, I think this was a great first, exchange. I think that we have got to come to a point where we can see if we can reach agreement on 138% of the federal poverty. And so if y'all can work on that this afternoon, and perhaps we can gather back up, announce another meeting, and we'll see where our two sides are on that. And if we can,
I hadn't gotten to ask
Oh.
my questions yet.
oh, well, go ahead.
I mean,
Sorry.
there are three of us.
Yeah, I was going to recognize you when she was through speaking.
I wasn't ending it. I just was saying, let's
Let you-
address that, which I believe is the first obstacle that the two sides have to agree on.
Senator Wiggins, go ahead.
Thank you, Mr. Chairman. I think it's good that we're acknowledging that, okay? And while we're acknowledging things, I think that it's important to acknowledge that for those who have said, well, we're just not going to take federal money, let's be honest with ourselves. We do that in this state every single legislative session. Medicaid, when I was chairman, was I said it, $1 billion state dollars, $7 billion total, which meant $6 billion of federal dollars. So to say that we're not going to take federal dollars is disingenuous as far as I'm concerned. I hear it in the media and I hear it other places. Not y'all.
You're not accusing us. Okay.
But that being said, okay, there is a real concern about the exchanges, and from what I've been told and what I've read and what I've researched is that when you take and go up to the 138%, then let's just call it the benefits start, you get into a negative situation financially, okay? And let me say this, I'm trying to keep this on we've been doing a lot of high level talking, so I'm trying to bring it down to a lower level. So the fact that you're acknowledging the exchange makes a lot of sense to me, okay, to do that. So I think, yes, we get back to where we look at the exchange and preserve those that are on the exchange to do that. And what we are really talking about when we are talking about Medicaid is is a health insurance program funded by the state. That's bottom line, that's what it is. And the recognition is we got people in this state who are working who don't have access to health insurance because of the type of jobs they're in. Okay, that's a problem created by the federal government and others. And so I think we're trying to solve a solution. But to your point, Madam Chair, about we were 44 states, I've said that, but actually one of the good things about going, let's just call it in the middle or last, is you get to correct what the mistakes were done previously. I simply, I will use I think the medical marijuana program was an example. We heard from states all across the country, from Oklahoma to Michigan, on all ends of the spectrum, and I think we got a good program for the state. So I think that's what the Senate is trying to do, is to get us a program that works, that we can say, hey, these people who are working, then we want them to have insurance. And we want them, because they're working, to have health insurance, because guess what? The market's not helping them right now. So we want them, but it has to be fiscally responsible. And I think you acknowledged that under Senator Blackwell's points, that the reality is that it's been a negative financial basis to states when they've expanded. And we're trying to, if not outright, eliminate that, minimize that. That's why our plan is what it is. And I think while we're talking brass tacks, we have to realize what the votes are. And I think y'all have done that by moving a little bit, because the Senate votes on what some of the media have called an austere program is what it is. And we have a veto-proof vote right now. So I think that those are things that we have to acknowledge that we're trying to get to and that we're having to deal with in this. The numbers are going to tend to be where they are. So, you know, I think, yes, getting back to working this out is a good thing. But there are people in this state who want to see it fiscally responsible. But we've heard from preachers, we've heard from doctors, we've heard from the State Medical Association, Mississippi Manufacturers Association, the MEC. We've heard from groups all across this state who support us trying to find a solution. It's not easy, but I think we're trying to get there. And, but, you know, I think this is a first step, and we need to try to work on this to get there. But my question, so that's a long introduction to a question, which is if we're trying to get to the 138%, okay, and you're saying we keep the exchanges in place, how does that look to y'all? I know, and I'm asking, let's put it in terms that, you know, what people are we talking about? And okay, so 0 to 100%, where would they be? Okay, through the MCOs. Okay, and then 100% to 138, where would they be managed?
They would be on the exchange.
Right, okay. They would be on the exchange, and then does that allow us to draw down the money?
Yes, we believe that CMS would approve that if we pay the cost sharing, if we pay the deductibles and pay the copays. They pay that in Arkansas, although this is a hybrid model, because 0 to 99 is on the MCOs, okay? The delivery is just like our Medicaid program right now. 100 to 138 would be on the exchange, but we have to provide we would have to pay the copays and the deductibles to be approved under ACA. And
the premiums as well.
Once those roll off, yes, but we would still preserve the exchange. And again, in the Hilltop study, they provide, and I think I have provided this to y'all. I know, Mr. Chairman, I have given it to you, and I think, Anyway,
But okay, so that's where we are. Have y'all looked at the Michigan plan? Because the Michigan plan, from my research, has been touted as a budget neutral plan that has worked. Now, that's going back a couple years and would need to look at that, but the Michigan plan has been touted as budget neutral and allowing to do some of the things that we're talking about. Have we looked at that?
I have not looked at that. But based on the numbers that we're looking at a savings to the state. So, we believe that we can do that, and with the cost offsets included,
Our plan would be a savings, whereas 44 other states have not been that way.
I can't speak to 40 for other states.
Well, I think that's the data that's out there, and that's what we're trying to get to.
Senator Boyd, all right.
House plan and about the maximum federal poverty level that we propose, but the Senate really hasn't explained what their reimbursement is going to be at 100%. I mean, what are your numbers with regard to that? What's the match on that?
The Senate plan is looking at the 77% rate. And the reason for that though is because we are looking at a smaller population of people. And so because we're looking at that smaller population of people, the cost actually winds up being less because we're going to leave that 100 to 138, which is, depending on which reports you look at right now, is anywhere from 150 to 180,000. So because what they're saying from Kaiser, it's about a 74,000 population. So when you look at those numbers on that, you do the MCO tax rate, and that's what Kevin went through at the very beginning. Looking at those tax rates, the numbers Kevin went through on that. So, and we're upside, basically looking at those numbers and usage and all that, we're upside over a little bit over $1 million. We get through with that.
So basically, you're just getting the current FMAT reimbursement for your individuals.
Reimbursement. But we looked at it, we decided that when we were looking at the original proposal, that everybody keeps talking about this 90%, that we want to get to 90%. The question we have to ask ourselves is that is it better off to leave these people with the federal government, what they supplement on this? Are we better off to leave them? And I think that's the question we're all trying to get to, just to be honest. Is it better to leave that, take the lesser FMAP, and then make sure that those people are still made whole and get the insurance that they do from 38%? And that's what the Senate looked at when we originally did it. What y'all are kind of saying right now is it's better to go ahead and with the 90%. And that's where I think our numbers are different. And I know the report that you're talking about, we got different numbers than they did, quite frankly, on that. So I think it's important that we start saying, okay, these are the numbers that we're going to use to get to that, because our numbers are different at the end of the day. Because that would be the question I would ask too. One of the things too that was impressed upon us by the Senate is to really see something that's revenue neutral. And I think that's something y'all were kind of shooting to. So given the numbers that we were given, I would ask to say, do y'all have another funding source besides the MCO tax? Because using the numbers that we were given, we would need another funding source. Do y'all have another funding source besides the MCO tax at this point?
Yeah, we believe that the MCO tax would, based on our cost, would cover that. But where are your numbers coming from?
That's exactly. That's what.
Where are you getting these numbers that you're saying are different than our numbers?
Well, we looked at the Hilltop report, and then we direct source some of the numbers of like usage rate, but usage and then the premium payments that they were doing in Arkansas on those plans. That we just had different numbers in it. So, and we need just to see how far our numbers are.
Yeah. So again, our source is the Hilltop. So I'd be interested. We would be more than happy to look at the source that you're using if you can provide us those numbers. going back to the Michigan, did you say Michigan? So is the Michigan study, is that a part of, is Michigan, I'll get all my states mixed up, but it seems like is Michigan 0 to 99 delivered through the MCOs? And then it's a hybrid model as well?
I do think it's a hybrid model. I'm, without having it in front of me, I'm not going to say where the percentages are, but I think it is a hybrid
Okay,
model.
so, but you asked me if I had seen the Michigan model, and so thinking back on what
Also, what they've done with that money is they created health savings accounts for the people that are on there, which goes to the point that you made earlier, Madam Chair, which is what I was making when I was chairman, which is the population. We need to get our population healthy. We need to get them. And first of all, they're not going to be healthy if they're not being treated. Second of all, part of it is behavior. Now, our MCOs in this state have worked to, with the people that are covered to try to improve their behavior so that we can have, and look, I'm no skinny Adonis, I will admit that, okay? So I could do better at trying to be healthy. My point is, we all can use the help to do that, right? And that's what Michigan did, was they used their dollars as an incentive to change to modify behaviors to create healthier outcomes, which is what we've tried to do in this state. I don't know that everybody in every state has tried to do that. I think that y'all are willing to do that, and we need to be looking at that. So back to Michigan, they created what was called health savings accounts. And if you know anything about health savings accounts in the private market, you are able to put money away to save it. You can use it how you basically want it. It's tax-free, tax deductible. And it's a good incentive plan to allow these people to address their health behavior. So that's more of the Michigan plan. I do think it is a hybrid plan of sorts.
So similar to what we are proposing. Yes, because ours is a hybrid plan. Part stays with the MCOs, and then the others that are eligible for the exchange, because 0 to 99 are not even eligible for the exchange. So, based on the paying the premiums and things such as that.
But to that point, and y'all were, I'm sorry, Mr. Chairman, y'all were not, the purpose of this is to move people from a Medicaid, a government to a private type of
Yes,
commercial insurance. This is a safety net, not a permanent net.
absolutely. And so,
So that's the idea.
and so thus our compromise position, because our original bill took from 0 to 138, all managed through the MCOs. We have heard the concerns about the exchange. We have heard the concerns about not destroying the exchange, giving people this additional option, private option, if you want to call it a private option. And so, so we feel like that is, a major compromise for that. And so we submit that to you. With regard to health savings accounts, we are willing to discuss all those things, and we have other ideas that would bring us together. But I think until our sides can get together on where we're going to go in terms of the federal poverty level and drawing down the maximum dollars from the federal government, which is a 90-10 match, plus another 650 or $700 million. We believe that we have got to find common ground on that. And then the details of, there are a lot of other things to consider, but I believe that is the critical starting point for our two sides. And so we submit that to you guys. Happy for y'all to take a look at that, discuss it, and resume the conversation.
Certainly appreciate that. You and I had discussions about keeping people on the exchange and came back with different proposals.
This being the proposal, right?
In we're trying to provide coverage for that group that they call the coverage gap. People that for some reason qualify for benefits, that's 0 to up to 9. So that's the population we were looking to help, because the other people have that they are on the exchange. So it's kind of the government, the federal government's already paying for it, so it's kind of hard for us to justify, why are we going the opposite direction? I'm not sure, when you presented the bill, I think you're probably up there about 2.5 minutes. I know you were over in our chamber, I think that was about 2.5 hours. Something, like that through our chamber is gonna be a little bit more difficult. But, I too am willing to, want to continue, and I think, I don't know, probably taking as far as we can today, but, is there anything you'd like to close on or anything?
No, I appreciate that, Mr. Chairman. We would just, present to you, see what your membership thinks about our idea of getting to 138%, of drawing down the maximum federal dollars, of also, a 650 or $700 million, incentive that goes a long way. And perhaps if your membership understands the benefits and the rationale for needing to get to 138%, because we're maximizing the federal dollar. And like Senator Wiggins said, we take federal money all the time. In fact,
I'm not necessarily saying that's a great thing. I'm just.
That
saying
we-
that's
but we
what-
do.
I'm just saying that's what happened.
we do. And look what it has meant. Look what it has meant to our hospitals. The enhanced MHAP that was approved, late last year, early this year. I mean, our hospitals have clearly stated that it has been a game changer for our hospitals. And I'm very grateful that is happening, and it's really helped them tremendously. That is
Let's be realistic on that. I've heard people who are Republicans, who I know and vote in Republican primaries, say other states are getting this money and we're getting none of it.
You
Okay?
mean for
Well,
expansion.
just In
No.
that sense, and it's going, but that's the same way. I mean, that's how these things work. So, we just have to we're cognizant of that.
But I'm saying we took the federal dollar for the hospitals and cheerfully, and we have been so pleased that the governor came up with the proposal back in the fall to provide this enhanced MHAP,
Yeah,
which
technically it was a raise in taxes that the governor proposed that drew down the federal dollars.
so
So it was
for
a
the
raise in
hospitals.
taxes
But they're
on
paying, they're
hospitals.
paying in to draw down more.
They-
But I don't think any hospital in the state of Mississippi is not happy about that. And so the hospitals have received great benefit from bringing more federal dollars down, really same pot of money. The House is just trying to answer the other side, and that is to provide health care for the individuals, because the hospitals have been given that. Obviously, this would continue to help hospitals, and we know that every year we are scraping together all that we can to help our hospitals and our rural hospitals. And so we believe that hospitals have benefited in the past several months. And this would just be another big step for our hospitals. But the priority of this initiative is to provide health care for individuals, to have to find a primary care home where they can be treated for,
But I think it's important on that to understand why, because I don't know that everybody does. The reason why it's important is because our hospitals in this state are treating a ton of uncompensated care. That's the reality.
absolutely.
And that's in part why the governor did what he did. So it's about the uncompensated, because I'm going to use in my district, Singing River Hospital, if somebody comes in a car wreck and they're treated in the emergency room, they're not being turned away. They're being
Of
treated.
course, they have to
But
treat
that
them.
treatment, and they don't have insurance, that cost goes somewhere.
Absolutely.
And that's what we're trying to look at and be smart about.
Yes.
Can I ask a question? Do you have the numbers for people that are above 100% poverty level to 138 that don't have insurance, that our hospitals are providing uncompensated care for? So that's a legitimate question, like Senator Wiggins said. Some of our hospitals are providing uncompensated care, and under the House plan, if you go up to 138, then them hospitals will receive some compensation for that care. So I think we need to look into that, because your numbers may not be assuming everyone is on the exchange at 100 to 138. So our hospitals are providing the care, and I think it's something we need to continue as we move it through the process.
Glad you got that word in.
Get that in one more time. So.
On, all right, I just, are you aware of the CMS new ruling or proposal that they're going to take a look at how we, the provider tax component, because they feel we're making too much money paying the hospitals, so that could also jeopardize it. So just as we move forward, we need to keep that in consideration. I want to thank Senators Boyd and Wiggins, along with our staff. I should have introduced Brittany Davis before. She's our our policy advisor, Pam Mims, who's our drafting attorney, and certainly appreciate you guys and your collective staff. Right. We appreciate all the hard. So, so why I realize our efforts here today may have not resulted in a compromise. I think at least we've, despite our differing opinions, have begun a dialogue that has not occurred in this building since the Affordable Care Act was passed in 2010. Despite it taking it so long to get here, I believe we're moving in the right direction. And I, for one, hope we continue. I view our situation as a journey. I think I can recall a Chinese proverb that says that every journey begins with a single step. And in the House's case, I think you guys want to jump in a sports car and zoom right to expansion, dam the roadblocks and get there. Those of us in the center want to take sort of a more slower approach to that. Well,
And so I don't feel like we have been in a Ferrari very long. I think we have been waiting 10 years. So we believe that the hardworking Mississippians we don't need to push the off anymore. Our low income yet hardworking Mississippians, they've waited.
well,
That's why we're the deliberative body on this side of the table.
well, here's the bottom line. Going back to the journey, both chambers are off the porch. We've both taken steps forward, something that has not occurred, and I don't think a lot of people would ever thought would have occurred here. If your position is going to be your way or the highway, and no pun intended, you're going to put us right back on the porch. So what I'm asking you to do is I'm encouraging you to go back to your side, to your members. You sat in our deliberation. Consider joining us in the journey. The Senate we want to move forward, not backwards. And I'm just saying, take a step with us. In the years to come, we can continue to work on this and refine it so we can provide health care for our hardworking Mississippians. Sure.
You both have your positions and then you compromise to work out and meet in the middle. So it's not our way or the highway by no means, because we have moved off of our original position, getting to 100 and present that. So perhaps your membership, hearing the numbers.
You were there. The reality is the Senate is not going to accept that position. So what I'm saying is we've got an easier position. I know it's not what you guys prefer, but we're moving. If this dies, it's going to be harder next year for us to get here. And damn sure it's not getting brought up in the next 2 years. So that's just, you and I need to continue dialogue. We've been having, been doing that, working good together. So I think we can continue to do that.
That's all I can say. That is,
We'll do that and take ours to yours.
yes. Well, yours is your existing position.
Right.
We have moved off of our existing position. So your position is.
Right.
I mean, we're trying to meet you. We're trying to meet you at a place. We have moved off our saying your position is still only your position, what?
Your mic-
Oh, if your position has not changed, then I don't have anything to take back. But what I'm saying today is we have moved off of our original position. So I would just submit that to you. Take that and, look at the numbers and I'll be happy to look at your numbers if you can, provide those.
Marking off, just knowing, because I've seen the report you have, we're working off, we're working completely off of different sets of numbers.
Yeah, so, but I don't know what your numbers are. I don't, so we
We can
We
get
have
together.
provided you with our numbers.
Okay.
So if y'all want to provide us with the numbers that you're working off of, we would certainly, do our due diligence in looking into those numbers.
Can you provide us with the numbers between 100 and 138 that are on the exchange and the amount of people you think that's uncompensated care that's not on the exchange?
We can provide the numbers who are on the exchange.
Okay.
I'm not sure about off the.
Okay.
Yes,
Oh, well, your plan earlier had said it's going to not take people off, but then you recognize that hospitals are providing uncompensated care for individuals in that range. Okay, so that's not taken into account at your plan or the plan you took to the Senate.
no, in fact, our plan wouldn't cover that population.
Okay.
Just 0 up to 100.
Thank you.
But you've offered and I'll accept, we'll continue to work this. We're not at deadline yet, so we still have, opportunity in front of us. So appreciate you guys coming.
Thank you. Thank
Thanks.
you so much.